Good morning, everyone. It's now 10 o'clock. I'm Nancy White. I'm the Education Chair for the San Diego County Breastfeeding Coalition, and I want to welcome you to the second of our World Breastfeeding Week National Breastfeeding Month webinars. Due to COVID-19, we're unable to have our traditional large-scale in-person seminar. This is the second webinar in the series of 5. We hope you enjoyed Carol Bartle last week on breastfeeding and climate change. From here on, all of the webinars will be at 10 a.m. The Zoom question and answer function is live, so if you'd put your questions in, we'll be happy to answer them probably at the end of the seminar. You'll receive a link to an evaluation form and a link to the recorded webinar within a couple of days. Your certificate of attendance will be mailed to you. As you may be aware, the theme for 2020 World Breastfeeding Week is Support Breastfeeding for a Healthier Planet. With COVID-19 still very present, we're seeing more mothers looking for information on relactation in order to help protect their infants. We are very lucky to have with us Carolina Ochoa. She's a mother-baby nurse, an international board-certified lactation consultant, and a researcher. She has close to a decade of experience in serving breastfeeding families in both inpatient and outpatient settings, and she currently runs a successful private practice in Inland Empire, California, in Redlands. Her areas of emphasis are clinical, management of lactation, behavioral feeding aversions, as well as implementation and management of lactation programs in different healthcare settings. Carolina is passionate about addressing the inequality in access to lactation professionals across the U.S. She's a big advocate of extended maternity leave for all parents. I wish I had it when I was breastfeeding. She lives with her husband, Julio, and 2 lively toddlers in Redlands, California, but she's speaking right now from France. So welcome, Carolina.
Hello, thank you so much for inviting me to do this webinar. This is absolutely one of my favorite subjects to speak on. I will now share my screen for the presentation. All right. And there we are. Perfect. So I like to call the relactation process magical because there's something absolutely so special about the ability to produce milk, even despite it being 2 weeks, 2 months, 2 years, or even 20 years. So this word is absolutely perfect to describe the process. And I also use it with parents, and it really, really helps. All right. I would love to tell you about my own journey with relactation. I am a mom of a special needs son, and when I stopped breastfeeding, I was happy and I felt like, no more pumping, no more this, no more that. And then the flu season came, and then my special needs son was at that point 2 years old. And I felt that he was really missing out on these antibodies. And it's been already 6 months from the time that I stopped breastfeeding. And I felt that I really want to do this. And I spoke to mothers multiple times about relactation, and I decided, like, I can do that. And it was hard. It was very hard. I was very happy that I was able to achieve my goal. However, it was not easy. So it was the turning point where it really became my passion to talk about relactation and inducing lactation with healthcare professionals. So I would love to share with you information about relactating, not only from the standpoint of like, oh, how does it work, but also like, how does it affect families? How does it affect mothers? And what we can do to support them, not only from the point of knowledge, but more than anything from the point of like emotional support. So we are definitely going to dive a little bit deeper into that. All right, but what hides under the term relactation itself? So it's just a process of restarting breastfeeding from the point that it was stopped. Again, it can happen 2 months, 2 years, or even 20 years after it has been stopped. And there are often information and research that even grandmothers that already achieved menopause were able to relactate for their grandchildren. So it's absolutely possible at any stage. And relactation is different from induced lactation, as relactation is for mothers that previously lactated. And induced lactation is for mothers that have not been pregnant and have not breastfed before. Why do families choose to relactate? There's a ton of reasons. The most common one that mothers come to me with is that they were producing so little milk that they just eventually gave up because it was not worth it. And very often they regret that decision, and then they will come and say like, hey, I really want to actually start producing milk again. How can I do that? Maternal infant separation. This is what we are definitely seeing right now. At least I am seeing that in my practice. Now that we are urging not to separate mothers and infants with COVID, it is kind of changing, but just a couple of months ago, it was definitely a big fear of mothers that they are going to be separated from their infants, and it was happening. So definitely when there is a maternal or infant separation, maybe mom has gotten sick, maybe she had a postpartum hemorrhage, maybe the baby is sick and mom was too distressed to even think about breastfeeding or pumping in those early days. So that definitely makes for an important reason to stop breastfeeding and then want to relactate. Resolved life crisis. So that can be a sudden onset of postpartum depression, postpartum anxiety, psychosis. That can be a divorce. That can be just a lot of different situations where we just, oh, I'm sorry, there we go. Where there's something that happens in life and we're unable to continue breastfeeding or pumping the way that we wanted. Sometimes, for example, this is what I've heard from my husband's family. My husband is Hispanic, and one of his cousins has lost someone close, and she was advised to stop breastfeeding because when she's grieving, it's not good for the baby to get her milk. So there are different situations in life and different things that people hear, and during that life crisis, that can definitely happen. Moms just cannot continue. It's just too hard. Formula intolerance. There are moms that are set on formula feeding their baby from day one, and they do so, and after, let's say, 2-3 weeks, their baby is just not tolerating formula, and they change and they switch 1, 2, 3 different brands, and nothing is helping. And that's when they get the feeling, maybe this is something that we can try. We've tried every single brand, why not trying our own? So this is how that can happen. Unnecessary weaning. And very often, this is something that happens so often that I wish it didn't. Medical professionals offer advice on having to stop breastfeeding with certain medications or surgeries. And very often, even if it's a short period of time, it can make a huge impact on milk supply. And then from unnecessary weaning for a few days, we go into low milk supply. Mom is working so hard and her milk is a third of what it was. And then again, it is very hard to continue fighting. And again, the suggested ways to increase the milk supply are just too hard. The triple feeding, pumping around the clock, breastfeeding the baby. So very often moms stop then, and then whenever the situation with the baby gets a little bit easier, the baby is around maybe 2-3 months old, not maybe 6 weeks anymore, that's when they are ready to think about relactating again. And regret, that's another reason why some families choose to relactate, and that is a really strong one. Sometimes moms feel like, yes, this is the end, this is what I want to do, I can't take this for one more minute, and then when it's done, they feel that they made a mistake. And it doesn't mean that they did. I just want to make it very clear. But it means that at the point when they were ready to wean, it felt like the right choice. But as soon as they are done, maybe a week passed, maybe 2, maybe a month, and they feel like maybe it was a premature decision to stop breastfeeding, and they might wish to relactate. Before I go into talking about how to relactate, I want to talk about how not to even do that in the first place. So what can we do to support mothers so they do not even have the need to start with? And this has been an important part of the WHO relactation booklet. And mothers that receive an adequate support from healthcare professionals in their community, they would rarely have a need for relactation. So for example, if in your practice, you suddenly see an uptick of mothers coming to you saying that they would like to relactate, it's a good indication to take a closer look what is happening in the community and what could be improved, so these moms would not even have to have that problem to start with. So when we want to look at the community, when we want to look at initiation of breastfeeding at the hospital, and what is being done by the pediatric offices in the area, by nurses on the floor, is the hospital a baby-friendly hospital? All that can definitely have a big impact. So anytime you see an uptick is a really good time to take a closer look at what is happening in your community, that there is a need for relactation. All right. As far as physiology of relactation, the relactation process always starts with the growth of the secretory alveoli. Not always it is necessary to relactate. And we know that mothers, for example, with induced lactation that has never been pregnant before, so they've never given birth before, they're actually able to produce breast milk without a very significant growth. These mothers are very often on birth control and then on domperidone. And with these moms, we noticed that even though there was not much of the significance in growth, they're still able to produce breast milk. Then there's secretion, and those secretory alveoli, they start producing breast milk, and then removal by infant or by pump or hand expression. As far as how the whole process looks like, everything really starts with the sensory impulse from the nipple, from baby suckling or from the pump, and that creates a little signal to our brain to start producing prolactin. So this little cycle is very important because this helps mothers understand that in order to start producing milk, we will have to start stimulating the nipple, stimulate the breast, that there is no magic pill that will increase the milk supply if you're not having that continuous suckling and removal of milk. So this is usually a good way to explain to parents why, even though like we can use medication or we can have herbs, we will still have to have the baby suckle at the breast, and we'll still have to use the breast pump to remove the milk. The role of prolactin is just so extremely important, and it is produced by the pituitary gland. And in lactation, relactation, induced lactation, this is still the most important hormone in the process. And as we discussed on the previous slide, it is produced in response to nipple stimulation. And it really does not matter if it's a stimulation from an infant or a stimulation from the pump. I often hear from lactation professionals that if the baby is removing milk, then the process is easier, the process is faster. But this is only true if the mother does not have the right fit of the flange. So for the mom that actually chooses to relactate via pump and is not wishing to breastfeed, it's important that we avoid saying that something is better than the other thing, just simply because we have no data to prove that. And second, because we don't want to make that mom feel like she is doing anything less than something absolutely magical and amazing just because she's not putting the baby directly at the breast. So with prolactin, when the baby is at the breast or when we have the pump attached, the sensory nerve impulses, they pass from the nipple to the brain, which causes secretion of prolactin. And in a non-lactating breast, the prolactin will stimulate the growth of the secretory alveoli. And once these develop, prolactin will stimulate these cells to produce and secrete breast milk. But just as we mentioned before, we can actually start producing milk even before we have a significant growth of the secretory alveoli. All right, what about oxytocin though, right? Because we hear all the time that there's two important hormones, correct? Prolactin and oxytocin. So how does oxytocin play a role in relactation? Surprisingly, it doesn't play a major role, especially at the beginning, because oxytocin is also produced by the pituitary gland, just like prolactin, and it also responds to suckling. So what it causes the contraction of the secretory alveoli, and it kind of pushes the breast milk towards the nipple. So it's the same contraction as the uterus pushing the baby out. The same thing happens with the secretory alveoli. Oxytocin, again, does not seem to be very helpful in the relactation process, especially at the beginning when there is very little breast milk available in the breast. However, it does become important later on when we need to remove larger amounts of breast milk through the pump or via infant suckling. So again, at the beginning, not so very important, but later on, it will play more major role. As far as the milk removal, it is very important, especially at the beginning, to remove all the milk there is available in the breast to increase and maintain the milk production. So a lot of moms that I work with, they will tell me, oh, when I pump every 2 hours, I get 2 ounces. But when I pump every 5 hours, I get so much more. And then we talk about how the breast produces milk per hour rather than, suddenly getting that larger amount of milk. And sometimes we even sit down and put the numbers together and we talk about, look, when you're pumping every 2 hours, you get 2 ounces. And when you pump 6 hours, you're getting 4 ounces. But when you look at that, you should actually be making a little bit more. That should be around 6 ounces have you pumped every 2 hours, but it was only 4 ounces because when your breast has gotten full, it has slowed down the process of making milk. So this also what works really well in explaining that to mothers is to compare it to an ice maker, right? So what happens is when we have ice in an ice maker and we take it all out, right? It starts producing ice and it starts to do it pretty rapidly. But what happens with the ice maker when it actually reaches the top? It doesn't produce any more ice, right? Because it will just like absolutely exit our freezer and open the door. So that would not be a good thing. So this usually works really well at explaining to families why is it important not to let breast milk sit in your breasts for too long, and why is it important to remove that breast milk very, very frequently. So remember that the next time you're going to be working with the mom, remind yourself about that ice creation in your freezer. So suckling plus milk removal plus prolactin increase is a key to relactation. There's literally nothing more important on the hormonal level and on the physiological level to the process of relactation than this. So with the milk removal, what I do with the mothers that I work with that are, let's say, had a pretty significant gap from the time they stop breastfeeding to the time they start breastfeeding is I usually send them home with a 1 cc syringe. So it really feels good if you can fill up a 1 cc syringe and you can feel so accomplished. And we can compare that if I have given them a 10 cc syringe or 5 cc syringe, then this would not be such an achievement. So if you run your own private practice, or if you work in a clinic and you work with moms that are willing to relactate, just try to send them home with a 1 cc syringes, because at the beginning it will make them feel so accomplished because they will feel like, yeah, I filled it up. So it's important to tell them that even though there's very little milk available at the beginning of the process of relactation, taking it out will only make it the process faster. All right. So as far as clinical management, there are so many factors to consider when a patient reaches out to you about relactation. What I usually like to start with is I want to learn about the circumstances. So I want to understand, why is this parent wanting to relactate? And what are these patient goals? Like, is this patient thinking about wanting to have a full milk supply? Is this patient thinking about milk donation and wanting a certain amount of ounces per day? Is this parent really only interested, in producing just 2 ounces of breast milk for your toddler for health reasons, right? So there is just a lot of different circumstances that parents decide to relactate because of. So learning that goal will be your first step, because it will help you understand, okay, if this mom only wants to produce 2 ounces of breast milk, it's going to be a different management of her expectations versus if the mom comes to you and she says that she has twins and she stopped breastfeeding 4 months ago and she would like to produce full milk supply for her twins, right? And full milk supply for twins, that's around, I want to say, close to 50 ounces a day, sometimes more, depending on how much the babies are eating. So that will help you manage the expectations for that parent. As far as baby's age, this is of importance because if the mom desires to get the baby back at the breast, knowing the baby's age will again help us manage expectations and come up with ways that we can get that baby back at the breast. This factor is of non-importance if the mother desires to exclusively pump because it's just going to be a pump and we don't have to worry about the baby willing or not willing to attach. According to research, we know that past 3 months of age, only around 50% of infants were willing to suckle at the breast for the first time. So there was a research done and they were looking at what is the age that we can really expect that baby to be suckling at the breast. And usually babies between 0 and 3 weeks of age would only be a case for induced lactation. Those babies were absolutely willing to suck on an empty breast and did not struggle with that. Then 8 weeks seems to be another mark. At 8 weeks, around 70% of babies were willing to latch on. And then again, at 3 months, we had a much lower amount of babies, 50% or less, of babies that were willing to latch on at the breast. That doesn't mean that this is the percentage of babies that went on to latching. This just talks about that first contact with the breast after a break, to see what is the chance of the baby getting back at the breast. Another important factor is the time that has passed from the last milk expression. And sometimes that can vary greatly. Again, we can have a mom that is adopting a baby and last time she breastfed was 12 years ago, right? It's still going to be relactation, not induced lactation, but it's going to be a significant amount of time. And then we can have a mom that is reaching out to you that she actually stopped breastfeeding 2.5 weeks ago because she had a surgery and she was told that she cannot breastfeed after surgery for a certain amount of time. And then she reaches out to you and that conversation is going to be completely different. So this is why you want to know how long has it been since that parent stopped breastfeeding or last expressed breast milk via breast pump. And another important factor is if this is something that we are going to do with the use of medication, or this is something that we are not going to use any medication or herbs throughout the process. So there are medications and herbs that can aid in the relactation process, but depending on the geographical region of your patient, it will play a big factor in being able to obtain medication and get care from a provider that will support you in that decision. So for example, in Canada, this is less of a problem, and in the United States, this is a little bit tougher situation because it's not a problem of prescription, it's a problem of filling that prescription. With other medications, there's also significant side effects. So this is definitely something that when we're having that first conversation with a patient, it's really important to inquire, are you considering aiding the relactation process with the use of medication? And that will usually give you a good idea of what this mom desires to do. I want to go back a little bit to the circumstances. And when that parent comes to you and wants to talk about relactation, we again want to discuss her reasons and her motivation for relactating. And that is because number one thing that mothers quote to be their motivation for relactating is health reasons for their child. So this is very important. We want to discuss the past ability to produce the full milk supply, but most importantly, we want to assess what is the support system for this mom, from her family, from her community, from her health workers, from healthcare professionals. So this is very, very important during that first initial visit when you are seeing the parent and you're discussing the motivation. If the mom experienced breastfeeding problems prior to weaning, we really need to dig a little bit deeper to understand what was the root cause, and then try to find solutions. Because if we do not find the root cause, for example, insufficient glandular tissue, then we can give this mom so much advice, and we are not really managing her expectations well unless we do a full intake visit and inquire about all these things. So again, if mom had breastfeeding problems prior to weaning, prior to stopping breastfeeding, we really want to understand what happened. Why did this mom stop breastfeeding? What was going on? We want to understand what is the individual goal for this mom. So just as we were in the previous slide, goals can be so different, and we cannot assume easily that this mom wants to produce a full milk supply. And maybe she doesn't even know that this is an option. Maybe she is considering relactation but is worried, how is she going to manage? And then maybe talking to her that you don't have to do 100% or 0%, that there's like 100 numbers in the middle that we can absolutely use and find something that is perfect for that specific family. So with the individual goal for this mom, it will also help us trying to understand what techniques can we use with this parent. So for example, if this mom desires to relactate via pump, then we are going to use different techniques for relactation compared to the mom that is wanting to relactate via infant suckling at the breast. I can't stress enough that relactation can be an extremely time-consuming process. So it is so extremely important to make sure that this mother understands the time and effort it will be necessary to produce breast milk, again, especially in significant amounts, just like the mom of twins that we discussed, right? If she stopped breastfeeding and she's not producing any breast milk and she wants to relactate and have a full milk supply for her twins, we're talking again around 50 ounces. We really need to talk about if this is even possible for that mom, right? She already has twins. Maybe she even has a toddler additionally. How is she going to manage? We need to ask all these questions, because if we don't, we're setting this mom up for disappointment. And this will be a huge heartbreak for her, especially after she has put so much energy into the relactation process. And then she feels like she has been cheated because it is so much harder than what she expected. So if we, and I'm not saying that we have to paint relactation as this awful process that it's impossible to achieve, but it's very important that we are honest with our patients. And we don't, it's the similar situation when, if we talk that breastfeeding is so easy and so simple, all the moms that are actually struggling, they feel like they're losers. They feel like they're doing something wrong. So again, language is so important when working with moms. Again, we want to make sure that before that mom leaves your office, she understands that it can be time consuming. And together, you can actually come up with things that could be helpful to make relactation process maybe easier. So we want to talk about the obstacles, right? Maybe the problem is that this mom might not have enough time during the day to pump. So maybe we have to come up with an alternate pumping schedule for this mother, right? And discussing how to resolve this ahead of time will really prepare that mom for when it comes to happen. And she will feel better prepared. She will feel more confident, and she's more likely to continue rather than to give up on a bad day. So just like we already discussed partially in previous slides, babies that still have the sucking reflex are much easier to get back at the breast compared to those babies that have lost sucking reflex. We can compare that to, for example, introducing a bottle, right? We know that there is a specific window of bottle introduction, especially for parents that are going back to work. And we want to make sure that if we know ahead of time that this mom has told us, hey, at 15 weeks, I am returning to work and I am a nurse, I work 12-hour days, and my baby will have to take a bottle during the time, that we instruct this mom that it's very important to introduce the bottle in the first between the week 3 and 4 of life. I know that very often lactation consultants will say that that window is actually a little bit longer than that, but it seems to be a little bit earlier than we initially thought. I honestly know plenty of babies that if the bottle was introduced after week 8, it was much harder for that baby to be able to learn how to take the bottle. So we can also look at it a very similar way. So if the baby has, let's say, breastfed only for the first week of life, and then mom wants to relactate and she comes to us when her babies are 3 months old, again, we want to manage expectations. We want to manage techniques that we're using. Will this baby need a nipple shield? Will this baby be happy with no milk in the breast, or will this baby easily take an SNS? So a lot of factors. And to dive back into it, as we discussed previously, babies in the first weeks of life are less upset when there is not a significant amount of breast milk available in the breast, versus a baby that is 4 months old will be less likely to want to continue to suckle when there is not a significant amount of breast milk in the breast. What will happen is mom will attach the baby to the breast, baby might even latch on, baby might suckle for 2 or 3 minutes and then scream, and then we have that negative experience at the breast that we really don't want to have. But we are going to talk about solution for that a little later in the presentation. So when speaking with the mom, just help her manage expectations. If she wants to get the baby back at the breast, and if that baby is older than 6 months old and already has complementary foods, that is going to be much harder. If that mom comes to you around 5, when her baby is 5 months old, it is also important to talk about complementary foods. So if mother is willing to relactate, her baby is around 5 months old, we want to make sure that this mom waits with starting solids until the 6-month mark. Because if we start earlier, then the baby is just filling up on calories and might be less likely to suckle. The same thing at 4 months. We know that there are parents out there that already introduced solid foods at 4 months. So we want to talk to that parent that it might be a good idea to actually stop solid foods, especially if the baby is under 6 months old. We don't want to stop solid foods when the baby is over 6 months, but we might want to consider stopping solid foods when the baby is younger than 6 months old. And again, that doesn't mean it's impossible. It is also important to talk about what happens if the mom weans the baby that is 6 months old, right? Because that happens. So the older the baby is and the longer the baby has breastfed, the less we have to worry about the gap. So just to give you an idea, let's say the baby that is 4 months old has gotten bottles and was not breastfed, and then the mom is wanting to relactate 4 weeks later, right? This might be harder compared to an 8-month-old baby that has been breastfeeding for 8 months, and let's say the gap is 5 or 6 weeks. This baby might actually surprisingly be more likely because it has breastfed for such a long time, and that might actually be easier than with that 4-month-old baby. So there's so many different things, and that's why it's so magical, because it can be so different. And there were times that I've absolutely, in my head, I know the numbers, I know the statistics. So sometimes when I come into a consult, I have to correct myself often on that, but I will come in and I will think that the chances are pretty slim, and there I have this baby that is like 6.5 months old and just starts to breastfeed, and we put the SNS and baby takes in 3-4 ounces, and they're extremely happy. And this is just something that just happens. So never assume 100% what's going to happen. You might know the numbers, but then there's just so many cases where babies and moms just surprise us. So this is very, very important to remember. All right. As far as how the time that has passed from last milk expression or breastfeeding session, how does this affect the success of relactation? On average, it may take about the same amount of time to produce a full milk supply as it has passed since the mother has weaned, provided she had a full milk supply. If the mom was already supplementing with formula, maybe baby was only 50% breastfed, or maybe mom was pumping and she was only producing 10 ounces per day, then obviously it can take a more significant amount of time for her to produce a full milk supply to relactate. If the mother's menses have returned, that can also play a role. It may take significantly longer when mom's menses has returned, and she might need the calcium, zinc, and magnesium supplements from day 14 of the cycle to the first day of menses. And if they're still experiencing the dip in milk supply, that first day can actually change to third and fourth day of their cycle. The longer it has been, the older the baby is, this just decreases the chances of getting the baby back at the breast, but it does not decrease the chances of mother producing milk if she's willing to pump. So that is very, very, very important. And that's why we want to learn what is the goal for that mom so we can advise her better. All right, we're again going back. We're going back to the decision if the mom wants to relactate using medication, or does she prefer to not use any medication during her relactation journey. And there are medications and herbs that really help. And it is very important that mother discusses possible risks and benefits of using any medications or herbs while breastfeeding with her healthcare provider. We can also counsel on that. We can guide the parents into resources that are available so they can make an informed decision. And it's important that if we have certain biases towards medications, or maybe we actually feel very strongly about the use of medication and relactation, that we listen to the family and that we let them make their own choice, understanding the risks and benefits. So that risk-benefit ratio, I very often bring it up during my consults, because this is something that they have to make a decision on. If we suggest, then it's not going to be as easy for them, especially, you know, with domperidone, with Reglan, there's always side effects. So it's important that they make that decision, so you don't have to be responsible for that mom coming back to you and say, hey, like, this has not worked for me. I'm really worried. I've experienced XYZ. So again, this has to be their choice, and it has to be discussed with the medical provider. All right, so what do we do if you've done everything that we talked about? You have learned about the goal for that mom. You've understood what her support systems are. You have learned how old is the baby, how old has the gap been since the mother has last breastfed. And now, what do we do with all that information? How do we get the baby back at the breast after the mother has stopped breastfeeding if this is what she desires? All right, so bottles and pacifiers, and parents do not want to hear that. Trust me, they really do not, especially if we have babies that just love their binkies. It's so hard to hear that actually taking that away can help. So we want to discuss how limiting or eliminating the use of pacifiers and bottles can help with getting the baby back at the breast, right? We want to teach the mom how to feed her younger baby using a cup or syringe or SNS. So it's really, really important. Usually what I say is the more stimulation at the breast, the faster your milk will come in. So if your baby's suckling on a pacifier, that process just gets significantly longer. So if the mother has the time, if she's willing to, tell her, just whenever you feel like your baby needs a pacifier, it's okay to attach your baby to the breast. And it doesn't mean that you become a pacifier, because nursing is so much more than just being a human pacifier or a human bottle. So this is something important to remember. Find the root cause. Again, just like we discussed, if mother stopped because of pain, bleeding nipples, maybe low milk supply despite pumping 12 times a day and breastfeeding the baby on top of that, we really want to find the root cause. I sometimes see patients and they talk to me that they already consulted with an IBCLC, and I learned that there was never any oral assessment done. Maybe the mother has not even shown her breast to the practitioner. Maybe there was not even a breastfeeding session that was observed. Those are such important factors. We really need to do these things. We need to check anatomy. If you're not certain about insufficient glandular tissue, breast hypoplasia, if you're an IBCLC, it is very important that you learn and dig deeper in these subjects. I know that some of us have learned about these issues prior to taking the test, but the test for IBCLC does really not go very much into detail in all that, especially the IGT or any hormonal issues, thyroid. Very, very important that you learn. There's so many amazing webinars out there that you can attend to really learn about that and then become more confident practitioner yourself. So again, find the root cause. We need to do that oral assessment. Now in the era of COVID, we might have to do that with the mom during telehealth consult. So don't be afraid to ask the mom to put a finger in her baby's mouth and let that baby suckle and ask her question. How does the palate feel? Does the palate feel like a big arch in an old European church, or does it feel like a spoon that is upside down? Maybe we want to learn about the gag reflex, right? Because if we see the mom is barely entering with the finger and that baby instantly gags, that is also very important information for us. What we want to learn is about how is the tongue moving. We can ask that mom, do you feel that the tongue is only moving in the front, or do you feel that wave-like motion that starts in the back of the tongue and goes towards the front of the tongue? So don't feel that telehealth is limiting your options for assessing oral restrictions. Think of it as trying to find a way how we can still get as close to our own assessment as if we were with that mom and baby during that consult one-on-one. As far as IGT, that will really help us to see what can we have as expectations for that parent, right? If the IGT is very significant, then we just need to manage expectations. It doesn't mean that breastfeeding is impossible. All right. If the infant is willing to latch on, we want to encourage the mom to put the baby to the breast very frequently. Every 1 to 2 hours. We really don't want that baby to get to the point of getting hangry. So when they're hungry, just enough to like, oh, I could eat. This is a perfect time. At least 8 to 12 times per day. They should offer both breasts for feeding whenever possible. If the baby gets frustrated and they do not want to stay on, we want to use something that is called a finish at the breast method that is described in the Making More Milk book. And this technique, what it means is we offer the baby a limited amount of supplement, formula, pumped breast milk that mom has stored in the freezer before breastfeeding. And we then avoid that hanger that we talked about, right? And that will make the baby more likely to actually stay longer at the breast and be a little bit more patient, even if the milk flow is not as fast as they were hoping for. If the infant is just completely unwilling to latch on, we want to assess for oral ties, plenty of skin to skin, rebirthing technique, and the bath. We can try at the breast supplementer. That is a great method for babies that are actually willing to latch on just a little bit, and then they don't want anything to do with the breast because it's empty. Or the drip drop method, and that is for the babies that are just kind of like doing the rooting around the breast, but they're unsure, like what are they supposed to do with that. So with the drip drop, we take a little cup or like a medicine cup, and we will drip or from the syringe, and we will just drip it down the breast, and hopefully the smell of milk will entice the baby enough to want to at least attempt latching on. We can also talk about nipple shields, and again, there's not one nipple shield that's perfect for all babies, but if the baby has oral restrictions, I really like the cherry-shaped nipple shield from MummyVac. So this is something to consider. Or if the baby needs both a nipple shield and a at-breast supplementer, then we can consider the Lally device. And what a Lally device is, it's a nipple shield that we can actually attach the syringe to. There's a little tubing that goes straight from the nipple shield, and that's like 2-in-1, nipple shield and SNS. And this can be really helpful for moms that need both, because Lord knows we all tried it, that doing both nipple shield and SNS just requires you to have 6 hands at the same time. And this is very often not sustainable for parents. So we need to find ways to make it a little bit easier. And we want to support the increase in milk production while the baby's trying to figure out the latching via pumping, at least 15 to 20 minutes every 2 to 3 hours around the clock. I can also see some questions coming. Please, 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 if you already have a question in mind, do not hesitate to put it in Q&A. And then as soon as we get to it, to the questions, I will answer as many as possible. So feel free to answer even right now while I'm talking, and we will get to it. All right, so what happens if mother desires to exclusively pump? Very often lactation consultants feel comfortable with the option of getting the baby back at the breast, but they feel a little bit lost when we're talking about exclusive pumping. So I really want to make it a little bit easier for you to understand how you can support that family. All right, it's important that the mom has a good quality breast pump. It doesn't mean that it has to be the hospital grade. Consumer grade pumps are really good, and they are much cheaper. There's no hassle of renting. So this is important. Another thing is important is that this mom knows how to use it. How many times I would get calls like, my pump is not working, and it just was missing the little duckbill in the middle, or the membrane in the medulla pumps. So you want to make sure that you understand how to use different pumps before you cancel your patients, and just know that all you have to do is YouTube it, and there's plenty of videos where it's explained how to use the biggest brands of breast pumps. Flange sizing. Make sure that the mother is pumping with the correct flange size. I have 3 golden rules. It is important that it feels comfortable. It is important that it empties the breast efficiently. And the third thing that is important is virtually no areola entering the neural tunnel. And I know that for many of you that sounds like, whoa, like, is that really a thing? Isn't it that with breastfeeding, we want as much of areola in the baby's mouth? Then why don't we do that with pumping? Well, pumping is different. The mechanism is different. And we really do not want too much areola entering, or like really at all, the narrow tunnel, because that can actually damage the ducts. So we want to make sure no areola entering the narrow tunnel. And many brands make flanges smaller than 21 millimeters, and they go all the way down to 13. The brands on Amazon that you can easily find, they're very inexpensive, $11, $12 for a flange set. Those would be Maymom and Mini Supply. And they make them compatible to Medulla, to Amida, to Spectra, so there's a variety. Another part is frequent emptying. So we really need to pump every 2 to 3 hours, 8 to 12 times per day. If the mom is anxious about her milk supply, or if she feels defeated because very little is coming out, I found this method by my colleague, and she has this great picture where she just puts a little sock on the bottle, and the mom cannot see how much is being pumped. Therefore, she can't really get too anxious, can she? So again, covering that bottle will help her stop focusing on how much, but how much stimulation, which is more important at the beginning than how much she really is taking out. Hand expression after pumping can really help yield additional breast milk. At the beginning, that milk can be a little thicker, especially if it kind of clogged the ducts while the mom was drying up. So getting some out with hand expression can actually be an addition to the stimulation with the pump. The middle of the night pump. Again, the last thing that the parents want to hear is that it would be really helpful if they would wake up in the middle of the night and pump. The pumping session around 2 to 3 a.m. is, I call it, the most important pump of the day, because your prolactin is naturally so high that, you know, it's like running with a strong wind behind you. So tell them that. Tell that parent that you're working with why is it so important that they wake up at night, and they will be more likely to do that. The second thing is to come up together with things that can help the middle of the night pump, right? We know that breast milk is stable in room temperature for a long time. If the mother does not have a medically fragile infant or preemie, she can actually leave the breast milk 6 to 8 hours in clean conditions on her nightstand. So for example, if she wakes up to pump at 2 to 3 a.m. in the morning, and the baby is going to be ready to feed even 6 hours later, or 5 hours, or 3 hours, or maybe she's just waiting to get up in the morning for the day, she does not need to have that trip to the kitchen to put the milk in the fridge. She can just leave it on her nightstand, or she can get a little cooler with ice prepared, and all she has to do is she has to sit down, put a pillow behind her back, plug in the pump, close her eyes, set an alarm for 20 minutes, and that's it. We do not want her to be on her phone. That really disrupts the melatonin production and then makes her tired the next day. And if she already has to pump 8 times a day, we cannot afford that. So we really need to make it easier. And again, coming up with ways to support that can be very, very helpful. All right. How does the right flange fit looks like? I have a little video here for you guys. We tested it and it was working, so I'm hoping that you will be able to see it. All right, so on the top with the green, we have the perfect fit for this mother's nipple. It's 15 millimeters. Actually, with that, mom, I wouldn't be afraid to even try a smaller size to see how it's fitting her, because some of her areola is still entering. And we see a really bad fit on the bottom, and you can see that nipple turning purple. That must be extremely painful. That's 27 millimeters. This is not the right fit for that mother. Usually the more elastic the breast tissue, the smaller, not larger, the smaller the size we want to choose for this mother. All right. Drugs and herbs that aid in relactation process. We have domperidone. Usually the starting dosage as per Canadian Breastfeeding Foundation and Dr. Jack Newman is 10 milligrams 4 times a day for 1 week. Then we can increase gradually up to 20 milligrams 4 times per day. There are side effects to this medication. It includes headaches, abdominal cramps, dry mouth, and pretty significant weight increase in a lot of mothers. So again, we want to make sure that the parent understands that. This medication is not FDA approved in the United States, but it doesn't mean that you shouldn't learn about it if you practice in the United States, because a mom can come to you and she might tell you, oh yes, I'm taking domperidone, I'm taking 420 milligrams per day. You need to understand that the highest dosage that we know of it being safe is 20 milligrams 4 times a day. So again, understanding what is proper dosaging is important, even if the medication is not legally available in the United States. Mom can come to you and she might already have the medication. Maybe she ordered in an online pharmacy. We still want to counsel that mother and help her how to be careful and how to be safe. Because if she doesn't get that advice from you or that support from you, she might not get it from her provider either. And she might just be on her own and listen to advice from other mothers on forums. And I'd rather her get advice from you than that. Reglan. Metoclopramide is very commonly used in the United States for nausea very often. The side effects include decrease in energy, diarrhea, headaches, drowsiness, restlessness, insomnia, increase in depression, anxiety symptoms. So never, ever do I recommend Reglan for any mother with history of postpartum anxiety or postpartum depression and with her current child. And I counsel pretty heavily if that mom has experienced any of that with previous pregnancies or even before she was pregnant. So remember, we really want to be very careful with Reglan with mothers with any history of depression or anxiety. It's not as effective as domperidone, but it can be helpful. Dosaging, we don't need to worry so much about that because since it is a FDA approved and legal drug in the United States, they usually already have care of their provider. Go through the suggested dosaging: 1 to 2 mLs of a tincture 2 to 3 times a day, or pills 700 milligrams twice a day. If the mother has diabetes, it is important to talk about the possibility of hypoglycemia when taking goat through, and she really needs to discuss with her doctor if it is safe. Blessed thistle, another one of my favorite herbs, dose up to 2 grams in capsule form. We know that more than 6 grams a day can cause vomiting. So let's stick to 2 grams a day, as it appears to be a pretty safe dosage. All right, how to gradually reduce supplementation. Maybe we already have that baby. Baby is back at the breast. Mom works on increasing her milk supply. So we need to slowly decrease that supplemental milk to encourage more enthusiastic and efficient breastfeeding. We have to be careful. We can do too much, we can do too little. So if we just do it too fast, then we have a hungry baby that is frustrated and the baby will not feed very effectively. So what I find very helpful is this little tables. So you want to reduce 50 milliliters every 24 to 48 hours. You don't want to reduce it in one feed. You want to reduce it 10 mLs in a feed. So let's say a baby is getting 60 mLs per feed. The baby's going to receive 50 instead in 5 feeds out of, let's say, 8, because that will make. Yes,
Carolina, this is Nancy. We're running really late.
Yes.
So
this is just one of the last slides, so we're almost done. And sorry.
And if you could answer that one question, so if that person has to leave.
Got it.
I have the conflicts of interest slide that we need to put up at the end. Okay.
Got it. All right. So there is a question. Have you observed any difference in outcomes when the mother is on birth control, specifically IUD? 100%. It definitely affects our estrogen, our progesterone, and with a high progesterone, obviously our body acts as if it's pregnant. So therefore ovulation doesn't occur. So it's really important to remember that all these things can affect the relactation process, and it's really important to talk to the mother about that before she starts her journey, especially if she has gotten on birth control that has both estrogen and progesterone. Those are much tougher to relactate on versus the progestin only, called mini pill, that would be much easier and much more possible. So definitely a good question. Oh, let me go back here. All right. So let's go back. So we want to do that for 7 days with the reduction. And after 7 days, we assess the weight. If the baby has gained 125 grams or more, we're good. If the baby has not gained 125 grams, we continue for another 7 days. And then if the baby still has not gained weight, we just want to start from the beginning again. So this is pretty important to remember, and it will make your practice much easier. All right, managing the expectations, we already talked about that, right? It's important for the mom to know that her worth is not ounces of breast milk that she can produce. So even a 1 teaspoon a day has 3 million germ killing cells. Bonding, doesn't matter if that mom's produced milk, just having the baby at the breast for bonding is absolutely amazing and very helpful. Oral development, again, even if there's very little milk available in the breast, it is still very, very helpful because of the dental health and the effects of breastfeeding on the development of the oral cavity. Emotional support, moms need to be kind to themselves. It's not easy. It's a process far from providing instant gratification. And they will spend many days and many hours seeing no effect of their hard work. So again, it's going to be easy to give up. If they reach out to you and are ready to give up, remind them of the reason why they started in the first place. So that first appointment that you had with them, their goals, their reasons, remind them why. Maybe you guys can write affirmations together to make it easier for another crisis, because it will come. And just never to give up on a bad day is my advice. As far as emotional support continued, it's okay if that mom is in distress, if she feels like quitting and she feels like it's just too much. Just again, it does not define her as a mother how much ounces of breast milk she can produce. She knows what's best for her baby. If she can't stimulate the milk supply, she has tried everything, or she feels that it is working, but it's just so much work and she cannot handle that. So again, we want to make sure that it's important to keep that baby just healthy and fed. And if that means formula, if that means solids, that is okay. So just be far away from judgmental and just be that person that says, hey, it's okay. And it's hard. It's very hard. All right. Now I answered the question that was in the Q&A. If anyone has another question, then I'll be happy to answer that. If not, it's been an absolute pleasure and honor to speak with you guys today. If you will have any additional questions to me, please feel free to reach out to me via email. I'm very, very happy to work with lactation professionals and help support their practice. So just email me at contact@carolinaochoa.com, and I will be, again, honored to support you.
Thank you so much, Carolina.
Of course.
We forgot to put up the, oops, where is it? We forgot to put up the initial slide with your declarations of industry support. Can you see them?
Yes, I can. Okay. If I can see them, I'm hoping that everyone can see it too.
See that. So I really want to thank Carolina for doing this from France.
From France, yes. And I promise this is not wine. This is just water.
Okay. And I want to say thank you so much for doing this. If you have any other questions, please you can send them to Carolina, or you can send them to the Breastfeeding Coalition at sgcbc@breastfeeding.org, and we'll get them to her. Please bear with us as we integrate and try to streamline all of the processes involved in the webinar. As you can see on the screen, you will receive an email with a link to a brief evaluation and instructions on how to receive your certificate of attendance. This was good for 1L CERF, and we will also have the recording available to SDCBC members and live webinar participants at no cost. And we hope to see you again next Saturday at 10 a.m. when Dr. Lori Feldman-Winter will update us on perinatal COVID-19. Everybody keep well, and thank you so very much for attending. Bye, Carolina. Have a good day.
Thank you, guys. Bye-bye.
Bye-bye.